الجزار.
Pulmonary manifestations in connective tissue diseases. First of all, connective tissue diseases related interstitial lung disease is sometimes the first presenting features of the connective tissue disease, which means that the patient come to us with no history of having rheumatoid arthritis, systemic lupus, or so on. He just have dyspnea or cough. So, connective tissue disease, interstitial lung disease, is frequently symmetrical and lower lobe predominant with volume loss. It has various manifestations. However, the most frequent pattern seen on high-resolution CT are in SIB or UIB. Connective tissue disease that have pulmonary manifestations like systemic sclerosis that occur in 90% of cases, myositis, and mixed connective tissue disease, rheumatoid arthritis, Sjogren syndrome, and systemic lupus. But what pattern occur? We have either fibrosing in SIB, UIB, organizing pneumonia and infection, diffuse alveolar damage, pleural precardial effusion, or bronchial wall thickening. So the pattern of fibrosing in SIB, it has a special pattern we should know. So there is epicobasal gradient, peribronchovascular GGO, spatial and temporal homogeneity, immediate subpleural sparing. Is an item we will discuss later. So, in this case, as we descend, there is epicobasal gradient, which means as we descend down, the pattern becomes more obvious in basal lung bilaterally. So also there is immediate subpleural sparing, which is characteristic for an SIB. That case describes the term temporal homogeneity, that on the same axial cut, I see diffuse pattern من الGGO, not just batches of normal lung and alternative GGO. So when there is in the same axial cut, there is diffuse GGO, so it is characteristic for fibrosing in SIB. So the epicobasal gradient is best visualized on coronary formatted images as we see here. The second pattern we have is UIB. On the past, there is no differentiation of patterns of UIB. It was when we see basal honeycombing, so it is UIB. If there is no honeycombing, no UIB. No, now they subcategorize the UIB into definite UIB, probable UIB, indeterminate, and alternative diagnosis. When there is honeycombing, so it is definite UIB. While probable UIB, there is no honeycombing, but there is subpleural and basal dominant fibrosis. Indeterminate pattern, it is subtle reticulation with subtle GGO, so I can't give a definite diagnosis of UIB or other feature. Our concern is about the alternative diagnosis, that there is features of UIB associated with other specific features, like cases of rheumatoid arthritis with specific pattern we will discuss later, other cases of scleroderma when there is dilated esophagus, and so on. So what specific signs we have? We should have to diagnose, so we are dealing with not ordinary case of UIB, but there is associated with connective tissue disease. So straight edge sign, 4-quadrant sign, which is specific for scleroderma, exuberant honeycombing, anterior upper lobe sign, which is pathognomonic for rheumatoid arthritis, and dilated esophagus highly associated with scleroderma. Our first sign is a straight edge sign. It is best visualized on coronary formatted images. We see as alike a imaginary edge sign between the normal lung and the affected lung. Another case that describes the meaning of straight edge sign, coronary formatted images, there is a straight edge between the normal lung and the affected lung. Other case of straight edge sign. The second sign is exuberant honeycombing, which means that more than 70% of the same axial cut have pattern of UIB. It is highly associated with connective tissue disease. The third pattern is anterior upper lobe sign. Most cases of UIB, we see basal subpleural articulation with honeycombing, but it sees basal. When I see it anterior at the upper lobe, it is pathognomonic for rheumatoid arthritis. Best visualized on sagittal reformatted images. There is anterior upper lobe, sign of honeycombing. as we see here, anterior upper lobe sign, which is pathognomonic for rheumatoid arthritis. The fourth pattern is the four corner sign. The four corner sign, on the same axial cut, I see the four corners of the lung are affected with honeycombing. Like we see, as we see here, it is best visualized, as we said, in the axial images. So the most important word that it is on the same axial image, I see the four corners of the lung are affected, bilateral anterior and bilateral posterior. It is highly associated in cases with systemic sclerosis. So other specific sign is the dilated esophagus, which is highly associated with scleroderma, and this is specific for scleroderma. When I see a dilated esophagus, either there is honeycombing, there is GGO, there is reticulation, but there is dilated esophagus, it is highly specific for scleroderma. Another case of dilated esophagus, in cases with scleroderma, there is no honeycombing, there is just GGO. Organizing pneumonia, there is areas of consolidation with surrounding GGO. Sometimes they told that it is transitioning to FNSIB. Lymphocytic interstitial pneumonia, there is a small prevascular scattered prevascular cyst that I see simple cyst with related vascular structure passing through it. So it is an LIB highly associated with Sjogren syndrome. Our take-home message: connective tissue disease, interstitial lung disease is underdiagnosed. Lung manifestation may be the only or the first presenting manifestation. The baseline lung function, prognosis, and treatment of connective tissue disease written interstitial lung disease differs from that of idiopathic interstitial lung disease, so the distinction is clinically important. Thank you.
السلام عليكم. في البداية طبعا جزيل الشكر الدعوة الكريمة من الدكتورة رانيا رأفت على حضور المؤتمر اللي كالعادة بيسري يعني وبنستفيد وبيجمعونا. لسه كنا بنقول للدكتورة رانيا يعني التجمع والمعرفة ده في حد ذاته قيمة وقامة عالية. جزيل الشكر طبعا للدكتورة مرام اولا على تكبدها المسافه من دانها، وطبعا خلت one of the most challenging بالنسبه لنا simplified targeted to the point. هايله بصراحه، محاضره شيقه جدا. وزاد من سعادتي ان انا اقدم الدكتوره شيماء. انا بين اتنين تشست على فكره، يعني لينا فيكو اكتر من الراديولوجي صح؟ فادعو دلوقتي الدكتوره شيماء آسف